University College of Medical Sciences and GTB Hospital, Delhi. Induced hypotension. Dr. Emini Afrai. University College of Medical Sciences and GTB Hospital, Delhi. Induced hypotension definition and objectives. Historical background. Purpose. Indications. Techniques with physiological basis, drugs. Contraindications. Limitations. Postoperative care. Specific applications. Current status. Definition. A technique that lowers blood pressure, BP, to reduce blood loss and the need for transfusion during surgery and to improve the quality of surgical field. Also known as deliberate hypotension, controlled hypotension, hypotensive anesthesia. Objectives: fallen systolic BP to 80 to 90 mm of mercury. Fallen mean arterial pressure MAP to 50 to 65 mm of mercury. Fallen 30% of MAP in hypertensive patients. In majority of cases, optimum operating conditions are the goal, not a specific pressure. Good communication between anesthetist and surgeon is essential. Historical background. Harvey Cushing proposed in 1917. Gardner practiced first in 1946. Griffith and Gillies used high spinal analgesia. Enderby used ganglionic blockers. Trimetophan. Sodium nitroprusside SNP-1962. Halothane. Beta-adrenergic blockers. Nitroglycerine and labetalol 1970. Purpose: less infection transmission, reduction in blood loss. Hemodynamic and metabolic stability. Less transfusion requirements. Less infection transmission. Improvement of surgical field. Improved visualization, better and faster surgery. Facilitation of vascular surgery. Prevention of progressive stretching of thin walls of vessels, easier suturing and clipping, aortic surgery, AVM, intracranial aneurysm clipping. Indications. Neurosurgery, AVM, intracranial aneurysm, vascular tumors, transsphenoidal hypophysectomy. Major orthopedic surgery, spinal surgery, shoulder/hip arthroplasty. ENT surgery, middle ear surgery. Head and neck, faciamaxillary tumors, block dissection of neck, laryngectomy. Indications. Ophthalmic surgery, intraocular tumors, vitrectomy, orbital surgery. Pelvic, major gynecological or rectal surgery. Plastic and reconstructive surgery. Jehovah's Witness. Techniques: physical measures. A. Postural maneuvers, keeping operated area higher than heart. Risk: air embolism. B. Artificial ventilation, lowers BP secondary to decreased venous return. Pharmacological agents. Effects of posture on local blood pressure. Pharmacological agents. Characteristics of an ideal agent. Easy to administer. Short onset time. Effect should disappear quickly on discontinuation. Rapid elimination. No toxic metabolites. Negligible effects on vital organs. Predictable effect. Dose-dependent effect. No ideal hypotensive pharmacological agent exists. Classification: alone or as adjunct. Used alone as adjunct only. Calcium channel blockers: nicardipine. Beta blockers: propranolol, esmolol. Phenyldopam. As adjunct only. ACE inhibitors. Clonidine. Used alone. Inhalational anesthetics. Sodium nitroprusside. Nitroglycerine. Trimetophan. Prostaglandin E1, alprostadil. Adenosine. Remifentanil. Spinal/epi anesthesia. Principle of induced hypotension. BP equals cardiac output, CO, x peripheral vascular resistance, PVR. CO equals HRX/SFO. PVR alpha 1/R4. Reduction in CO should be avoided as organ perfusion may be compromised. Induce a low pressure, vasodilated circulation. Physiological effects of induced hypotension. Marked physiological response designed to restore BP back to within normal range. Central neuronal reflexes. Arterial baroreceptors. Cardiopulmonary receptors. Hormonal changes. Renin-angiotensin system. Catecholamines, physiological effects. Reflex rise in HR, myocardial contractility, vasomotor tone low pressure, hyperdynamic circulation. May result in increasing vasodilator doses. May require use of adjuncts, anesthetic agents drug site of action predominant action side effect. Bupivacaine, spinal/epidural. Medulla. Blockade of sympathetic nervous system. May need vasoconstrictor. Ropivacaine, spinal/epidural. Opioids, remifentanil. Heart, bradycardia. None. Inhalational anesthetics, isoflurane, sevoflurane. Vessels, vasodilatation. Blockade of alpha adrenoceptors. Resistance. Need high concentration of adjuvants. Vasodilators drug site of action predominant action. Side effect/problem. Sodium nitroprusside. Resistance/capacitance VSLS. Vasodilatation. Direct acting. Cyanide toxicity. Strict monitoring. Nitroglycerine. Capacitance vessels, vasodilatation. Resistance, strict. Monitoring. PGE1, alprostadil. Resistance vessels, vasodilatation. Heart-chronotropic. Cost. Calcium channel blockers, nicardipine. Heart-ionotropic. None. Phenyldopam. Dopamine DA1 receptor agonist. Adenosine. Cost. Histamine release. Autonomic nervous system inhibitors. Drugs. Site of action. Predominant action. Side effect. Trimethophan. Vessels, vasodilatation. Heart, contractility. Blockade of the ganglia of ANS. Histamine release. Resistance. Labetalol. Alpha, beta adrenoceptor antagonist. Slow onset. Esmolol. Heart, bradycardia. Contractility. Beta adrenoceptor antagonist. Cardiac failure. Clonidine. CNS. Presynaptic alpha adrenoceptor agonist. Unpredictable effect. ACE inhibitors. ACE inhibitors drug site of action predominant action side effect. Captopril, enalapril. Vessels, vasodilatation. Angiotensin inhibitors. Long duration of action. Sodium nitroprusside, SNP, nitroglycerine, NTG, labetalol. Characteristics. Sodium nitroprusside, SNP. Nitroglycerine, NTG. Labetalol. Onset of action. Rapid onset. Rapid recovery. Rapid onset, moderate slow recovery. Gradual onset. Slower recovery. Duration. Evanescent action. Short acting. Long acting. Method of administration. IV drip, 0.01% solution. IV drip, 0.01% in 5% D/W or 0.9% NS. For injection repeated in increment. Mode of action. Direct effect, resistance, capacitance vessels. Direct, capacitance vessels predominantly. Alpha and beta adrenoceptor antagonist. Tachycardia. Very common. May occur. None. Cardiac output. Depends on many factors: posture, HR, preload, afterload, drugs, volume status. Slight decrease. Blood-brain barrier. Pronounced dysfunction. Sodium nitroprusside, SNP, nitroglycerine, NTG, labetalol. Characteristics. Sodium nitroprusside, SNP. Nitroglycerine, NTG. Labetalol. Metabolism. Dicyanide, thiocyanate. Degraded rapidly in liver. Degraded in liver. Stability. Available as powder. Unstable when reconstituted. Protect from light and use within 12 hours. Stable, colorless. Absorbed by plastics. Stable. Dose. 0.5 to 1.5 grams/kg per minute. Total dose not to exceed 1.5 milligrams/kg in 4 hours. Plasma CN-Cong should not exceed 3 moles/L. Start, 10 to 20 micrograms per minute. 1 to 4 grams/kg per minute. 0.2 to 0.4 milligrams/kg followed by increment. Histamine release. Unknown. Rebound hypertension. Occurs in absence of beta blockade. Does not occur. Intracranial pressure. Increases in early stage. Increases. Does not increase. Cyanide toxicity, mechanism. Cyanide toxicity, manifestations. Resistance to high infusion rates of SNP. Metabolic acidosis, raised lactate levels. Elevated venous oxygen saturation. Progressive hypotension unresponsive to fluids and vasopressors but responsive to thiosulfate. Cardiovascular collapse. No specific laboratory test but lethal cyanide level in blood is approx 500 grams/dl. Cyanide toxicity, management. Sodium thiosulfate. Bolus injection, 30 mg/kg. Continuous infusion, 60 mg/kg per hour. Hydroxycobalamin, B12. Prevents CN-Conc. In erythrocytes. Bolus, 50 mg/kg. Infusion, 100 mg/kg per hour. Fluid replacement. Acidosis correction. Monitoring during induced hypotension. ECG-myocardial perfusion, drug effects. Accurate BP monitoring. Gold standard is direct intra-arterial measurement. Capnography, disconnection alarm, indicator of air embolism. Value as an index of PaCO2 is limited due to dead space. Pulse oximetry, allows adjustment of VO2 to compensate for VQ mismatch. EEG/evoked potential, reserved for neurosurgery, CPB, severe hypotension. Transcranial Doppler velocimetry. Safe conduct of induced hypotension. Onset and degree of hypotension. A reliable intravenous line. Horizontal position. Monitoring. Initiate only after intubation and steady in S state. Hypotension to be induced slowly over 10 to 15 minutes. Proper posture and optimal venous drainage. Adequate fluids but prevent overhydration. Safe conduct. Maintenance of near normal PaCO2 and acid-base balance. Hypocapnia, vasoconstriction. Alter blood pH. Increase oxygen consumption. Inhibit hypoxic pulmonary vasoconstriction. Safe conduct. Oxygenation increased intrapulmonary shunt. Decreased cardiac output. A high VO2, 0.4 to 0.5 or higher, during induced hypotension is recommended. Contraindications: inexperienced infants, pregnancy, fixed cardiac output. Coronary artery, renal, cerebral disease. Hypovolemia. Severe anemia. Limitation. Risk of tissue hypoxia by reducing microcirculatory autoregulation of vital organs and by inhibiting ANS. The goal is to maintain a pressure sufficiently low to allow reduction of bleeding without suppressing microcirculatory autoregulation of vital organs. Complications: coronary artery thrombosis, cerebral thrombosis, cardiac arrest, temporary and permanent neurologic deficit, failure of technique, resistance and rebound, postoperative reactionary hemorrhage, tissue trauma, postoperative care, maintenance of airway, provision of supplemental oxygen, analgesia, warm environment, respiratory and cardiovascular monitoring, adequacy of blood volume, positioning, specific applications, neurosurgery, cerebral aneurysm surgery, spinal surgery, scoliosis correction, ophthalmic surgery, ENT surgery, pregnancy, cerebral aneurysm surgery, low pressure circulation, reduces blood loss, improves visualization, reduces aneurysm transmural pressure, safe application of clip, reduces risk of intraoperative rupture. If aneurysm ruptures, less bleeding, rapid identification and control of bleeding point. Vasodilators started after opening dura to avoid an ICP. Avoid the technique in presence of preoperative vasospasm and if a feeding artery is to be temporarily clipped. Scoliosis surgery, general anesthesia. Monitoring of spinal cord function using wake-up test or somatosensory evoked potential. Blood loss is massive BP to be reduced slowly, preferably under SEP monitoring, and only to the point at which operating conditions become satisfactory. Ophthalmic surgery, ENT surgery. Uveal dissection, prevention of bleeding into vitreous. Choroidal melanoma, requires period of choroidal ischemia. ENT surgery. High level of difficulty and impossibility of controlling bleeding by using clamps on afferent vessels. Vertebral basilar artery and external carotid artery makes induced hypotension a choice in ENT surgery. Pregnancy, BP, uterine blood flow, fetal asphyxia. Hypotension not to be induced unless considered as life-saving measure. Nitroglycerine, least toxic. Close fetal heart rate monitoring mandatory, serves as a guide to safe level for hypotension and hyperventilation. Current status: surgeries with low/moderate bleeding potential. For example, middle ear, eye, neurosurgery. Induced hypotension used in light of benefit/risk ratio. Surgeries with moderate bleeding potential. For example, vascular, major orthopedic surgery. Benefit from combination of hemodilution with autologous transfusion with induced hypotension. Surgeries with high bleeding potential. For example, cardiac surgery/liver transplantation. Use of induced hypotension has decreased. Current status. The best efficacy combined with ease of use and lack of toxicity belongs to techniques of hypotensive anesthesia that associate analgesia and hypotension at clinical concentration. Epidural anesthesia, not always practical. Remifentanil along with propofol or inhalational agents at clinical concentration are preferred techniques because of their safety and ease of use.